Okay. Good afternoon, everyone. Welcome to the Pfizer-hosted symposium here at the FPSMID Virtual Convention. On behalf of Pfizer, I would like to thank the Philippine Society of Microbiology and Infectious Diseases for giving us the opportunity to partner with you on this event. My name is Michelle Mamburao. I'm the country brand lead of vaccines, and for today's session, if you have any questions, I encourage you to visit our booth, type in your questions on the chat box, and we will be more than happy to accommodate you. And now for the lecture, it is my honor to introduce our speaker this afternoon. He's the chairman of Adult Infectious Diseases and Tropical Medicine at San Lazaro Hospital. He's an ID attending physician at Manila Med, MCM, and Adventist Medical Center. He is an associate professor at the Department of Medicine at the University of the East Ramon Magsaysay Memorial Medical Center. He is also the past president of the FPSMID as well as the treasurer of the PCP. Dear doctors, please join me in welcoming Dr. Rontgene Solante.
Thank you, Michelle, for that kind introduction. And first of all, I would like to thank also Pfizer and congratulations to FPSMID for this 50th annual convention. Now, our topic for this afternoon is very important because this is something that most of us are very aware of but are hesitant to do. So defying the odds, the value of adult vaccination during a COVID-19 pandemic. If you look at the latest guideline by the CDC, this only emphasized the importance of immunization services and the need to really continue giving vaccines even during this pandemic. The fact that you also prevent vaccine-preventable diseases, it can also benefit our patients in reducing being infected and at the same time reducing the burden of respiratory illness during this upcoming influenza season. And furthermore, vaccination prevents illnesses that lead to unnecessary medical visits, hospitalization, that can also strain the healthcare system, which is already taking care of a lot of these COVID-19 patients. And its emphasis is really communicating the importance of this vaccination, particularly not only to patients at risk, but also to caregivers without differing any safety protocols and procedures. Now, consideration for routine vaccination during pandemics somehow has to be streamlined for those individuals that really need the vaccine. One, for children and adolescents, this can be recommended and this can be done through contact of parents to schedule in-person appointments. For pregnant individual, it should be part of a follow-up, and receiving these vaccinations like your Tdap and influenza is also an important prevention of this infection that are also common to complicate this population during the phase of pregnancy. And of course, giving or scheduling your adults to receive vaccines according to the adult immunization guideline, prioritizing older adults and those with underlying medical conditions who are at increased risk for complications of these vaccine-preventable diseases. In this particular slides, you'll notice that they specifically mentioned here the important populations by which reducing the burden of respiratory illness is of paramount importance in order to prevent mortality and at the same time complications, particularly the essential workers who are the front lines among our hospitals taking care of COVID-19, by which if this will be depleted, will be very critical in terms of the infrastructure workforce. But furthermore, there are also other populations that if they will be admitted because of respiratory illnesses, the presence of these vaccine-preventable diseases can also complicate and somehow increase the risk of mortality in a setting that this patient may also have COVID-19. And these are patients aged 65 years and older, particularly those who are residing in post-acute and long-term care facilities or any ages with certain medical or underlying medical conditions. There are also individuals that are higher risk for specific vaccine-preventable diseases like influenza, at higher risk for complications. These are infant age 6 months and older, including those 65 years and older. If you look at this particular data published by Joseph Faggio of the University of the Philippines, they found out that during this pandemic, during the early part of the pandemic, from December to February, there was really a low awareness of the influenza and pneumococcal vaccination. But as the pandemic has matured, starting at March, okay, there was increasing trend in terms of information and awareness on the importance of flu and pneumococcal vaccine. And I think in their findings that it may herald higher demand for pneumonia and influenza vaccines in the coming season, particularly given the fact that flu and pneumonia can also present with the same clinical manifestations, including possible complications, especially for those with COVID-19 infections. Going back to the importance of vaccination in adults and not just for kids, around 50,000 Americans die each year. We don't have a very good data here. That's why I'm using this particular slide just to more or less extrapolate how much of these adults at higher risk of developing vaccine-preventable diseases, and most of them also with chronic diseases developing more severe form of this infection. And the fact that the awareness of and the information that this population is at higher risk of severe infection, we notice that the coverage rate in terms of vaccines among this population, even with this routine recommendation, is still very low. Now, this is a worldwide estimate and projection of older population that is from 1990 to 2020 and from 2020 to 2050. If you take a closer look at the blue one, this is where the Philippines belong. And from 2020 to 2050, it seemed that our elderly population, those higher risk for vaccine preventable diseases, will be increasing. And in fact, in this particular projection, there will be an increase of around 20%, the current estimate of elderly population by 2020. In 2015, this is also coming from the Philippine Statistics Authority. 7.5% of the total population of Filipinas, okay, which is approximately like 7.5 million if the population is 100 million, are already senior citizens. And comprising a bulk of this group of senior citizens are aged 60 to 64 years old at 36%. And this is followed down the line 65 to 69 and then 70 years old and above. And you can just imagine the number, the population that will be at increased risk for these vaccine preventable diseases, causing a higher rate of mortality or even morbidity. In an economic burden of adult vaccine preventable diseases in the United States, these are the top 4 infections: influenza, pneumococcal disease, including zoster and pertussis, by which they estimated that the government spent around 6.5 billion just to treat and prevent, or more or less treat, the infection, including its complications. And in fact, this is the inpatient care unit cost for one hospitalized case for influenza and that for invasive meningococcal disease. Again, despite the recommendation and important data that this particular at-risk population are at higher risk for mortality and morbidity, in a country where program for immunization and vaccination is really robust and very concrete, you still see that the coverage or vaccination coverage is still very low. And in fact, in this list of vaccines, only tetanus toxoid and pneumococcal vaccination aged more than 65 years old were at 60% higher. And the rest, including that of your influenza, hepatitis B, and other vaccine preventable diseases, pale in comparison in terms of how many percent were given this particular vaccine. And this data was collated from 2010 and 2015. And you notice it has not changed from this 2010 to 2015. Another updated vaccination rates in this particular data, okay, you have hepatitis B, HPV, influenza, pneumococcal, and shingles. Okay? So the orange bar are the vaccination coverage rate, and the dark bar is the healthy people 2020 target. And it seemed uh, consistent that there are really very low coverage rates for this vaccine comparing to the target that we need to achieve for healthy people by 2020. And that includes your shingles, pneumococcal vaccine, and that of influenza. And again, this is a comparison of how low is the vaccination rate, particularly with pneumococcal vaccine, comparing the healthy people and then that of actual. These are the 65 years old and above. The vaccination coverage is only 60%. This is the data as of 2020 provided by CDC. And then the goal is 90%, still 30% short of the goal. And then for those high risk adults, meaning with comorbidities at age 18 to 64 years old, the goal here is 60%, but look at the actual vaccination coverage as low as 17% to 21%. And then the adults who are in long-term care or nursing homes that were vaccinated against pneumococcal disease, 18 years and above, the goal is 90%, but the actual and those vaccinated are between 67 to 79%. So coverage is always an important risk why we have breakthrough infections or epidemics of these vaccine preventable diseases in adults. In fact, when you look at the 2019-2020 data of the United States, their coverage for influenza last season was only 44% among this age group, and that 51% only of the high risk for pneumococcal disease has never been advised to get vaccinated against pneumococcal disease, by which we always associate pneumococcal disease as an infection that is commonly complicating a patient with influenza. In the Philippines, this is one data that I was able to gather that among retiring and retired UP employees, only 33 receive either a flu or a pneumonia vaccine. Despite very good data in terms of cost effectiveness, here they were able to compute the quality adjusted life years of several of these vaccines, meaning how much of this vaccine can add a single life year when given this particular vaccine. And it seemed consistent that receiving influenza and pneumococcal vaccine, including that of zoster and HPV, may also improve the quality adjusted life years, either by giving it as an age-based indication or the presence of comorbidities or chronic medical conditions. In the Philippines, in a result of the 2018 longitudinal study of aging and health in the Philippines, in which they were surveyed in terms of percent who are aware of pneumococcal vaccine for older persons, it seemed that the awareness is really very low. And in fact, those who were asked also if they have had pneumococcal vaccinations since they turned 60 years old, only a half of this group of population received a pneumococcal vaccination. A data coming from a study in which 42 anonymized private and public hospitals in Indonesia, Philippines, and Malaysia, in which the Philippines is represented by 18 hospitals, among the burden or what's the burden of pneumonia in the Philippines, looking at case fatality rate, either or both hospital-acquired pneumonia and community-acquired pneumonia. And it seemed that if you look at the red line here, this is the community-acquired pneumonia incidence, which is a bit lower compared to the hospital-acquired pneumonia incidence. But what I would like you to focus here is that if you look at the age group that are at higher risk already and with a substantial case fatality rate, it starts with your 50 years old. And then if you have, again, after that, you have 60 to 74. So there is an increasing risk of higher case fatality rate as we grow older. And this is something that why the need for prevention is really important among this age group. And then also, as we mentioned, that the presence of chronic medical conditions, even among patients with who are less than 50 years old, starting at 18 years old, can also increase the risk of community-acquired pneumonia. Okay? So here, this is the 1849 with chronic medical conditions. But as we grow older, it seemed that it will really play an important factor when you have patients with cardiovascular diseases, when you have patients with lung diseases that are really an important indicator of getting higher rate of community-acquired pneumonia. So at this point, we'll review the adult immunization schedule in the Philippines. Okay? This is based on the PSMID guideline. We'll start first with inactivated influenza vaccine. So our recommendation is anybody starting at 19 years old and above should receive one dose annually as much as possible. If the vaccine is already available, it should be given as early as February. For tetanus, diphtheria, and pertussis vaccine, once you are 19 years old and above, if you haven't had any tetanus vaccination, then if you're given 3 doses of your tetanus toxoid, the recommendation is at least one of that should be diphtheria pertussis containing tetanus toxoid in the form of your Tdap, and can be given as a booster every 10 years. Now, for measles, mumps, rubella vaccine, particularly with measles and mumps in adults, and particularly for the childbearing age women, rubella is also important. So for immunocompetent, at least you'll be receiving 1 dose of these MMR. But if you are at high risk, like student, healthcare workers, or a traveler, then 2 doses for MMR should be given 28 days interval. For hepatitis B, the same schedule, 0, 1, 6 months. And then specifically for hepatitis A, this is not routinely given, but only for those at high risk of getting hepatitis B based on occupation. Okay? So 2 to 3 doses are given, interval of 1 to 2 months. And then varicella is not routinely given, but particularly this is very important, especially for those healthcare workers who may be exposed to patients having varicella, and those without history of varicella infection should also receive 1 dose of your varicella vaccine. You can also give your varicella vaccine if you have been exposed with 72 hours within 72 hours post-exposure. Now, your pneumococcal vaccine is quite unique because we have 2 formulations. Okay? And I will specifically discuss this later on how to give this pneumococcal vaccine. Okay? And you have zoster vaccine. Our recommendation is we start giving it at 60 years old and above, at least 1 dose. The currently available vaccine is given at this age group, and no revaccination or boosting of the vaccine is needed at this point in time. For HPV vaccine, in the new recommendation, you can start giving HPV vaccine as early as 9 years old, up to 13 years old. And if you're going to give that, then you may only have to give using the quadrivalent vaccine between at least 2 doses before 13 years old. But once you are more than that age group, then you have to receive the 3 doses. The only update about HPV is that aside from the quadrivalent, you have additional serotype that is incorporated in the new nanovalent vaccine that will give you added protection against HPV serotype causing cancer, particularly cervical cancer. And then for Japanese encephalitis virus vaccine, since the Philippines is one of those countries where this infection or this virus causing encephalitis is highly endemic, then at least any time during adulthood, you have to receive a single dose and no booster needed. Then for the rest of the other vaccine, I will just have to specifically mention meningococcal vaccine because we also use this a lot, especially for our patients with HIV. and for those patients who are also immunocompromised, like those patients with asplenia, wherein 2 doses of this vaccine is also given to protect against serogroup of your Neisseria meningitidis, ACW, ACW and Y. Okay? Although there are reported cases now, particularly here in San Lazaro, where majority of our meningitis secondary to Neisseria meningitidis is now more on the B serogroup over that of A. And I think there is now a proposal that hopefully meningococcal vaccine containing B serogroup should also be available in our setting. Okay. This is the healthcare worker vaccination guide. And since this is the guidance that we use since 2012, and we have emphasized here that healthcare workers should also receive very important vaccines, strongly recommended, particularly the first line are your Tdap, hepatitis B, influenza, varicella, and MMR. And any healthcare worker with at risk for pneumococcal infection, pneumococcal vaccine is also recommended. And then for the recommended for selected healthcare workers with possible exposure or risk of exposure, like in those healthcare workers working in dog bite centers or those working in emergency room area, then either a rabies vaccine or meningococcal vaccine should also be given. And then for the support services like admitting section, ambulance driver, down the line, security personnel, social workers, there are 3 vaccines that we highly recommend. And these are your tetanus, diphtheria, and pertussis, hepatitis B, and influenza. And among the selected healthcare workers, like you're working in the dietary or kitchen, then hepatitis A and typhoid vaccine should also be part of those that should be given among our hospital staff worker. Now, this is the recommended adult immunization by age group, according to the ACIP of the United States. Okay, I want you to emphasize on this red boxed area. Okay, this is the use of pneumococcal conjugate and polysaccharide vaccine based on age indication in the United States. So if you'll notice, the violet one is a recommendation for adults with an additional risk factor for another indication. So not just for age. And the blue one are those by which there is recommendation based on shared clinical decision making. And I will explain this a bit later, no? Because you have to understand that there are areas here that may not be applicable to our own guideline here in the Philippines. Okay, and I think there are a lot of questions then. And when this guideline by the ACIP was released, there are Asian countries wondering why they're not including PCV13 in the one of the group here in the United States recommendation. Okay, so in this pneumococcal vaccine recommendation in the United States for adults 19 to 64 years old, okay, if you have this condition, immunocompetence, smoker, alcoholism, chronic heart disease, chronic liver disease, chronic lung disease, and even diabetes mellitus, then their recommendation is only giving PPV 23, okay, and not with a PCV 13. Okay? But if you have this condition like a cochlear implant, CSF leak, and then you have here congenital or acquired asplenia, sickle cell disease, immunodeficiencies, malignancy, HIV, leukemia, down the line, by which we call this as immunocompromised patients, then the recommendation is giving a PCV13 first, and then at least after 2 months, follow it up with your PPV23. And then for this group of severely immunocompromised, then you can give a single revaccination of your polysaccharide 23 5 years after the initial dose of your polysaccharide vaccine. Okay. So I think this is the area by which that if you are 65 years and above and you don't have any immunocompromising condition that we discussed in the previous slide, okay, and you don't have history of pneumococcal vaccine, in the United States, their recommendation is giving PPV 23. But looking at this blue one, this is based on shared clinical decision making. So meaning you have to discuss with the patient the importance or why they should not be given this vaccine, and in a way you have to give also when this vaccine can also be recommended. Okay, so this aspect, the shared clinical decision making, and if the patient will consent that he wants to receive a PCV13 based on the conditions that were stipulated by the US, then they can receive a PCV13, and then an interval of 1 year after that, they will receive your PPV 23. So what are the conditions that are considered as discussing patient that PCV 13 can still be given among this age group? One is if there is increased risk for exposure to PCV 13 serotypes. And what are these situations? If you are residing in a nursing home or other long-term care facilities, if you are in a setting where there is a low pediatric PCV13 vaccination uptake, or if you are traveling to an area with no pediatric PCV13 program. So this only means that the impact of PCV13 among the elderly due to herd immunity as a result of very good vaccination coverage among the children has somehow benefit this elderly. But if you are exposed in an area where you think that PCV13 has a lower uptake in this particular guideline, in this particular setting, then you need to be given a PCV13. And in fact, they somehow also recommend that having this condition, which increases the risk of developing pneumococcal disease, giving the PCV13, who had the additional 13 serotypes with a very good immunogenicity over that of PPV23, can also be an added recommendation and emphasis why you need to give this conjugate vaccine. And of course, if you are immunocompromised, 65 years and above, then there's no question. In the guideline, if you don't have history of any pneumococcal vaccination, then you have to receive what they call this PCV13, and then after 2 months, you can follow this up with PPV 23. For those patients who has received already PPV 23 before 65 years old, then the next vaccine that they should be receiving is PCV 13, at least with an interval of a year, and then give your PPV 23, and then 5 years after, you can also give a revaccination of your PPV 23. So you only need single revaccination in this age group. So remember, if PCV 13 was already given at 19 to 64 years old, then if they reach more than 65 years old, no additional PCV 13 is needed. Okay? And at the same time, no additional doses of PPV 23 should be administered following the dose administered at 65 years old and above. Okay. Our recommendation is more or less the same as that with the ACIP, except that it's so encompassing that any adult, okay, will receive both vaccine, okay, especially for those without history of pneumococcal vaccination. And to emphasize again, no need for revaccination with PPV 23 or PCV 13 is needed. Okay, and then for those adult who is more than 50 years of age, so our cutoff is 50 years of age and not 65 years old, and who has previously been given PPV 23, then obviously your next vaccine should be your PCV 13, interval of 1 year. For adults who previously received PPV 23 when they were 50 years old and below, and who are now 50 years old above, then they have to receive one dose of PCV 13 at least 1 year after the PPV 23, and then give another dose of PPV 23, 5 years interval, 1 year after the PCV 13. So you'll be giving PPV 23, PCV 13, and then another dose of your PPV 23. For adults more than 50 years of age who were previously given PPV 23 without any previous PCV 13, they can opt to be given another dose of PPV 23 after 5 years and no revaccination thereafter. Okay. So just to give you an important explanation here, what's the difference between the two? In terms of not necessarily the serotype that is in these vaccines, okay, but the how this vaccine perform in terms of immune antibody response. Okay, your polysaccharide vaccine is a T cell independent, so meaning antibody production is via B cells. So because of that, this vaccine stimulates your B cell without T cell involvement, and that's why you cannot give this among children less than 2 years old. And then second, in the absence of T cell immune response, there is limited immunological memory. Okay, so that's why it cannot be boosted. And giving it every 5 years can also induce tolerance. So meaning it will not add additional antibody production even if you give it every 5 years for several years. That's why the current guideline is only revaccination, one revaccination after 5 years. Now, your conjugate vaccine has a different pathway of stimulating your antibody response. And this is mediated by both T cells and B cells. Now, the advantage of T cell stimulation is that it can induce stimulation to your memory B cells. And that's why you have a longer duration of protection because not only it will stimulate your T cells, but also your B cells. In this manner, you have higher immunogenicity, so you have higher antibody level, better protection, and if even given consecutively, especially for children less than 2 years old, where the schedule is 3 to 1 or three doses interval of 1 month, then it can create a boosting effect without compromising any responsiveness or absence of hyporesponsiveness. The better part of your conjugation is that, especially in children, it can also eradicate the colonization of your Streptococcus pneumoniae in the nasopharyngeal area. So it can protect the colonization against colonization. And that's why when you give this to children, we're able to see now the benefit of herd immunity among the elderly for those who are exposed to children who have received the PCV13 because of less colonization and less ability to be transmitted to vulnerable populations, especially 65 years and above. Okay? So this is the reason why PCV13 should be given first before that of PPV23, the preference because of the benefit it showed in terms of immunogenicity. So when given first, it acts as a primer and it improves the immune response since it stimulates your B cells, which is also the important cells that your PPV23 will stimulate. So meaning it provides the highest level of protection because with stimulation of your B cells, your PPV23 will mainly stimulate the B cells to produce an antibody. So better to give your PCV13 over that of PPV23 in the immunization sequence. Now, I mentioned about the impact of PCV13 in the United States. When it was introduced in 2007 to 2008 among children, okay, they were able to observe that after 5 years of introduction and with a better and good coverage rate in children, the impact then was this is the herd immunity impact of the PCV13 in the United States. Before, it was the healthy adults that was documented to really benefit with the herd immunity, but also looking at those individuals with chronic medical conditions, especially with chronic lung diseases, heart diseases, okay, including diabetes, and then you have here solid organ malignancy, and those who are smokers. It seemed to be consistent that from 2007 and then after 5 years, there was a downtrend of invasive pneumococcal disease due to your 13 serotype that is contained in your PCV13. So in fact, the impact here can be construed as something significant, especially for the both 19 to 64 years old with chronic conditions, and more or less those 65 years old and above that are healthy without comorbid conditions, including that of immunocompromising conditions. When they look at the data, okay, it seemed that the IPD decline, starting from the healthy, chronic medical conditions, and then you have immunocompromised population, it seemed consistent that the vaccine type was also very important. In that those who received the PCV13 or in those who were exposed to receive the PCV13, there really was a significant decrease. Okay, whether you are 19 to 64 years old or 65 years old and above, from healthy to chronic medical conditions to immunocompromised, there is a significant drop in the PCV13 serotype causing IPD. And if you look at the PPV23, again, in fact, in these chronic medical conditions who receive PPV23, there's an increase in the cases, which meant that there's something wrong with the PPV23 in terms of protection, and basically, and most likely, because of its lower immunogenicity compared to the conjugate vaccine. And I think the current direction now in conjugate or pneumococcal vaccination is increase in the valency of the serotype that is contained in the vaccine, and more or less more on the conjugation rather than using the old formulation of a polysaccharide vaccine. Now we shift again to another infectious disease that can also be a burden causing respiratory illness, and that is influenza. So this is the WHO FluNet data in the Philippines. Okay, so these are color coded, and these are the serotypes of your influenza in the Philippines. We have the dark green, light green. These are the serotype A, influenza A, both H3 and 2, and H1 and 1, and then the orange and the dark or maroon color are the B lineage, either the Victoria and Yamagata. So there's no question all of these serotypes or serogroup are already present in the Philippines. Okay. Now, in an excess mortality data of influenza in the Philippines, based on this 2006 to 2015 comparative analysis using a weekly age disaggregated numbers of all cause of death, weekly percentage of the laboratory confirmed influenza A and B by the WHO, including that meteorological control, they found out that most common influenza in the Philippines is influenza A. Okay? But if you look at the excess death in terms of trending from 2006 to 2015, this is all ages, so it's increasing. Okay? So the yellow one is the predicted mortality, and the gray one is the actual mortality. And the increase was more significant among those individuals 60 years old and above. So it accounted for almost 5,424 excess death per year versus that of the 96 death per year that were registered by official death record. Okay, so the annual influenza associated mortality rate was like 5.33 per case per 100,000 person. And the most vulnerable population, as we always predict, are those 60 years old and above. And that's why in our recommendation, we now recommend that using a quadrivalent over that of a trivalent can also increase the protection and decrease the mortality rate. So before giving your vaccine, I think this is quite important. No? Just looking at something that most of us may not be doing routinely when we give our vaccines. And this is how to screen for contraindications and precautions. So these are some of the screening questions that we need to know and we need to ask our patients, so that if any of this is yes, then a more thorough evaluation should be done prior to vaccination. Okay, so like, do you have cancer or some immunocompromising conditions? And this is related with absolute contraindication to giving your live attenuated vaccines. And then there are also vaccines that are not recommended during pregnancy period. Okay, so how safe are vaccines? Very important that we need to communicate and we need to emphasize this to our patients, that vaccines is one of the safest interventions. The previous years, including the years that we've had lately, where the vaccine confidence is really low, brought about by a lot of factors aside from the anti-vaxxers, but what we call the individuals who would like to undermine the importance of adult vaccination. Then we have to really emphasize on this when we are talking to our patients, okay? And it seemed really logical that when you look at all of this emphasis on vaccine, side effect, adverse event, and contraindications, that vaccines is one of the safest interventions in public health. And just like any pharmaceutical product, adverse event can also occur, but uh, there may be serious adverse event, sometimes life-threatening. That's why monitoring, surveillance, including adverse event following immunization, should also be emphasized. In 2019, these are the top 10 threats to global health as uh, enumerated by the WHO. And one of that is vaccine hesitancy. And I think the reason then is because of vaccine hesitancy. A lot of these third world countries are reporting resurgence of previously eradicated or previously controlled vaccine preventable diseases. And I think the Philippines is one of that, wherein we are one of those countries that reported resurgence of polio, outbreak of measles, including that of pertussis and diphtheria that we somehow encountered here in San Lazaro. And I think this is the time that with COVID-19, this is the time that our confidence in vaccine should be emphasized. Okay, now that we have another pandemic in which coming years or coming months we may have the first vaccine for COVID-19, and we've heard a lot already about anti-vaxxers about COVID-19. It's not a good start to talk about bad effect of vaccine, but in this particular pandemic, we cannot postpone, we cannot delay vaccines, especially for if we're giving vaccines to benefit the at-risk population or the highly vulnerable population. In fact, in this WHO guidance on immunization, okay, if you have high risk if you're in a population where you have high risk vaccine preventable diseases that can potentially lead to outbreaks and cause mortality, and while there is an ongoing COVID community transmission, then immunization staff are engaged in COVID-19 preparedness and response. This is their recommendation. So explore alternate solutions that immunization will not be delayed, okay? Especially for this at-risk population. Develop list of cohorts of children who have missed their vaccine doses so that you can give the catch-up vaccination, and at the same time maintain and enhance surveillance against vaccine preventable diseases. Okay, so I had this particular article looking at important strategies, okay, for increasing immunization. And in fact, it's ironic, no? The ones that are recommending this and publish this are gastroenterologists and hepatologists. Why? Because their patients are also at risk of vaccine preventable diseases, being having a chronic liver diseases. Okay, so here is their suggestions, interventions, the level of evidence that they were able to support these interventions, and examples like client reminder and recall systems. You may have a reminder letter or message to patient, and then the other intervention is provider assessment and feedback. So evaluate the provider, practice performance, okay, and then standing orders, okay. So sometimes we need to do this, especially for those individuals admitted in the hospital before they can be discharged. If you have that opportunity to give these vaccines, then it's safe, okay. And then information system, state immunization registries, and then home visits, healthcare system-based interventions implemented in combination. So these are very helpful. We can also get some tips with these strategies and apply this in our setting. Increase the access. I think one of the important gaps in really the giving vaccines is lack of access to vaccines, because only a few are giving the vaccines, and I think most hospitals does not store vaccines in the pharmacy. Okay, So vaccines are not just for children, and adults can also be protected against these deadly infections. That's why we need to again revisit why the need and why to emphasize the importance of vaccines among our patients. Okay? So improving vaccination rates in our at-risk adult population should be an effort not only for ID, not only for pulmonologists, but everyone who has a patient at risk for developing this infection and possible complications. We can utilize strategies to ensure delivery of vaccination services, no, in this pandemic that I've shown here to prevent the potential dangerous scenario of multiple other epidemics due to these vaccine preventable diseases. And with that, the importance remains high even in the pandemic, which we call the preventive health. With that, thank you very much for your kind attention.
Anggapon Pilipino,
Walay Pilipino.
Walang Pilipino.
Wala sa Pilipino.
No Filipino.
No Filipino, regardless of age,
Place of birth.
or social status.
should die from a vaccine-preventable disease.
Bakunado ako.
Bakunado ako.
Bakunado ako.
Vacunado ako.
Bakunado ko yan.
Bakunado na ini.
Bakunado ah!
Ikaw, bakunado ka na ba?
Thank you very much, Dr. Solante, for the important information about vaccination, especially about the pneumococcal vaccine. I apologize that we cannot have the question and answer session anymore in the interest of time. And so on behalf of the board of the PSMID, I would like to thank Pfizer for partnering with us in mounting the 42nd annual convention of the PSMID. We felt that the scientific lessons that we will impart in this convention needs to be communicated now more than ever, and your partnership in this endeavor has helped to make this happen. We shall be sending the certificates of appreciation for Dr. Solante and for Pfizer by email. I'd like to thank everyone for attending this afternoon's lecture, and we look forward to seeing you in the main scientific sessions immediately following this. Please do not forget to exit this Zoom webinar room and click on the evening session Zoom link on the convention website. Thank you very much and see you later.